Hi, everybody. Welcome to this month's installment of the Global Emergency Medicine Residency Curriculum. My name is Nick Ludmer. I'm an assistant professor of emergency medicine at the University of Chicago, as well as an assistant director of our International Medical Education Fellowship. And this month, I'm going to be talking to you guys about the Basic Emergency Care Course, or BEC, which was developed by the World Health Organization, the International Committee of the Red Cross, and the International Federation for Emergency Medicine. Before we get into it, I have no disclaimers or disclosures. Big thank you to the developers of the emergency medicine residency curriculum. I've really enjoyed it so far, and it's a pleasure to be here talking to you guys about a topic that's near and dear to my heart. The outline for today's talk, we're going to start off talking a little bit about why the basic emergency care course was created. And in order to do that, we're going to talk a little bit about the history and the importance of emergency care in general, and why the need for developing and creating resources like the BEC is so important. Then we're going to go into what the BEC course is and really look at some of the nuts and bolts of what the course entails. So we're going to look at some of the materials the course contains, as well as where to find it. Then we're going to look at some of the data surrounding the implementation of the basic emergency care course. We're going to look at some of the initial pilot studies and what they showed. And then we're going to look at some subsequent studies as the courses continue to be rolled out in over 60 countries worldwide. And then for those of you who are already involved in the basic emergency care course or are thinking about implementing the basic emergency care course, we're also going to take a slight foray then into the world of medical education and talk about some of the other special considerations you need to keep in mind when implementing a basic emergency care course that don't come in a nice sort of prepackaged form that's available on the WHO website. And this is applicable to implementing the BEC, but really any medical education intervention, whether it be locally or globally. And then finally, we're going to talk about some future directions of the BEC, sort of where it's headed. And most importantly, what are some opportunities where you guys can get involved if you're interested? So without further ado, let's dive right in. So before we get into the content of the basic emergency care course and what it looks like, I think it's important to talk a little bit about why it was created in the first place and what the need for courses like the basic emergency care course is. In order to do that, we're going to review a little bit about why emergency care itself is important, and specifically why simple interventions such as training personnel in basic emergency care has the potential to make dramatic impacts on morbidity and mortality in the care for acute illnesses in places with developing emergency care systems. Now, I know talking about the importance of emergency care to what is likely an audience of largely emergency medicine physicians is a bit like preaching to the choir. But I think it's helpful to look back on sort of where emergency care came from as a specialty, and where the focus on emergency care sort of started to and began to grow, and the recognition for the need of developing emergency care systems kind of came from. So in order to do this, we're going to take a brief trip back in time, and we're actually going to recycle a timeline that you guys may have already seen before in a previous lecture in this series. This timeline was created by Dr. Rybarczyk as a part of her Global Health Equity lecture back in October. If you didn't get a chance to catch that lecture, it was excellent. Definitely recommend the watch. And thank you to Dr. Rybarczyk for developing such a wonderful timeline. And so we're going to kind of use that as a framework for looking at the development of emergency care and sort of why the development of the BEC is important. So starting at the top, back in the dark ages of EM, before any known dates, emergency care in the United States was very different than what we know and love today. Hospitals did have emergency rooms, they had emergency care areas. However, they were staffed by sort of a rotating cadre of moonlighting physicians who came from various specialties. Some also simply took call from home and weren't present within the hospital 24/7. So around that time in the 60s, 70s, it was noted that such a system sort of led to significant delays in care, and that many times the providers who were moonlighting in the ED lacked specialized training in caring for some of the emergencies and acute illnesses that were presenting to these emergency care areas. As such, in sort of the late 60s, early 70s, groups of physicians were sort of banding together and sort of dedicating themselves to the management of acute illnesses and the presentation in emergency rooms. And in 1975, we saw the development of the first emergency medicine residency and sort of the takeoff of emergency medicine as a specialty in itself. Uh, Around that same time, sort of 70s, 80s, 90s, the recognition of the importance of emergency care was also happening globally, not just in the United States. So up until this point, though, a lot of global health interventions kind of focused on public health interventions, uh, preventative management or preventative interventions, and then the management of non-communicable diseases, all of which is supremely important and don't want to detract from the importance of that work. But it also became more widely recognized that focusing on the management of acute illnesses as well was a huge opportunity to decrease morbidity and mortality and death from common issues. This was exemplified in a study from around that time. The study was done by Rozek et al. In 2002. And this table specifically highlights the 15 top causes of morbidity and mortality in low to middle income countries at that time. Many of which, as you can see, were from acute illness or acute decompensations and chronic illness. And it was also shown that a large percentage of these causes of death and morbidity could be greatly improved, or the outcomes could be greatly improved simply by the early recognition and initiation of treatment. So all the ones on this list that have sort of a darker blue or darker green highlight to them, all of those at the time of 2002 had dedicated research showing that simple, timely interventions could greatly reduce the morbidity and mortality due to these specific causes. So with that, as well as other research around the time, the WHO and other organizations began to recognize that by improving emergency care and the management of acute illness, we could greatly reduce the morbidity and mortality in different regions and around the world. So in 2007, the WHO released this resolution, 6022, which highlighted the need for the importance for participating nation states to think about how they could improve emergency care access within their country or region. This, by no means, was a step-by-step roadmap on how you do that and how you go about improving care, but it did put the development of emergency care sort of on the global radar. And emergency medicine and emergency care became a larger focus within local ministries of health, within NGOs, within private organizations, and the focus really began to grow. During the subsequent kind of 10 years, a lot of studies then came out sort of examining what is the current state of emergency care in sort of low to middle income countries at the time. And this study done by Obermeyer et al. In 2015 kind of took a look at sort of what emergency care looked like at that time in different areas. And so they did this largely by a literature search, by sort of literature review, searching for any studies that kind of outlined what the current status of emergency care was in certain regions. And ultimately they found that found papers examining emergency care in 59 countries. And in examining this data, they found that in general, emergency care needed improvement in a lot of areas. Some of the biggest barriers to care were, one, just general infrastructure, as well as lack of access. But two, one of the biggest barriers to adequate emergency care was the lack of training of hospital and healthcare personnel in the management of acute emergent complaints. As a result, within nation states, within the WHO and around the world, there was a big push for the development of sort of widely accessible and widely available training in basic emergency care to improve emergency care areas in the clinics and hospitals that already existed. So the WHO, along with the International Committee of the Red Cross and the International Federation of Emergency Medicine, teamed up with experts in emergency care as well as in medical education and decided to develop a course that they could make publicly available for free, that could be widely disseminated in order to start improving the general level of training in emergency care in emergency care areas around the world. And the end result of that effort was what we know and love as the basic emergency care course today. It was piloted through 2016, 2017, and its official release came out in 2018. So now that we've looked at sort of the development of the basic emergency care course, kind of why it was created and why it's important, let's talk a little bit about what the course entails and what it looks like. Um, Overall, the goal of the basic emergency care course is to provide uh, healthcare providers of all levels of training. So whether it's a layperson, a medical assistant, a nurse, a physician, provide medical providers of all levels of training uh, a basic framework for assessing patients who present with acute illness. Much of the course is structured around using sort of an ABCDE framework, so airway, breathing, circulation, disability, and exposure, similar to sort of a primary survey ATLS kind of framework. How to use that system of assessment to assess patients coming into acute care areas or presenting with emergent complaints, how to recognize signs and symptoms, and then also provide folks with a set of basic interventions that can be made, very simple interventions that can greatly improve outcomes. Generally, the course is delivered over a period of about 5 days and largely follows the structure you see on your screen. This was taken from the WHO website, where basically it starts off giving folks a framework of how to assess patients, so an ABCDE approach. Then it also gives you a specific method of assessment in trauma, so the ABCDE approach kind of expanded, similar to sort of ATLS kind of approach. And then it goes on to focus on specific parts of that assessment. So there's a day dedicated to airway, to breathing difficulties, to circulation and shock, and then sort of alter mental status. Each of those sort of gets a dedicated day, and ultimately the course, a lot of the time ends up taking about 5 days to complete. In addition to methods of assessment, not just the ABCDE approach, and talking about airway, breathing, circulation, disability, and altered mental status, the course dives into not just the assessment, but as you're doing the assessment, what are some of the basic interventions you can make to improve the patient's situation and begin kind of basic treatment and resuscitation. So this is an example taken from the course manual where it talks a little bit about the airway. And you can see it's kind of demonstrating what you look for in the assessment of the airway, paired right next to it with what are some of the immediate management options you have to sort of improve that finding. The course then dedicates, once they've sort of mastered the ABCD approach, it dedicates a lot of time to very specific presentations. So how do you assess the patient who comes in with difficulty breathing? And that gets an entire day. And then how do you assess the patient who comes in with signs of shock? And what do you do? And so this is an example of some additional content within the course, also pulled from the course manual, where it talks about some specific disease processes that might be going on in a patient who presents with difficulty breathing, for example. So it shows some of the signs and symptoms, what you might see when somebody presents with those complaints, with that illness, and then lists some of the basic management. And because it's a WHO developed course, all of the management, all the medications it recommends are sort of pulled from the WHO's recommended medication list. And then finally, in addition to giving a method of assessment, talking about specific complaints and approach to specific complaints, the course also focuses a lot on learning and developing key skills that you can use to implement those interventions. So in airway, it talks a lot about suctioning, repositioning, using oral pharyngeal airways and nasopharyngeal airways. In breathing, it talks about using a bag valve mask to assist breathing, supplemental oxygen, those kind of things. So overall, with that structure, has those different elements and generally takes about 5 days. All of these materials, one of the benefits of the BEC and one of the goals of the BEC was to make it widely accessible. So all of these materials are for free and are available through the WHO website. So one of the main components of the course is the course manual, which is downloadable, as you can see from the WHO website, and is available in multiple languages, including English, French, Spanish, Arabic, Dari, and others, which you can kind of get on request. And for instructors, if you think about putting on a basic emergency care course, not only does it have the participant manual available, which has all the content of the course, but it also has pre-prepared instructional materials. So the website has the lectures that you can use for the introduction of the course, the ABCDE method of assessment, the dedicated day on trauma assessment, difficulty breathing, shock, altered mental status. When you break it down, the course covers those topics, and it does so in a variety of ways. So the bulk of the course in teaching the material, a lot of it's didactic, and those are a framework for those is provided for you on the website, as we just saw. So about a third of the material is all kind of didactic form. Another third of the course comes in the form of skills teaching. So a lot of the time requirement of the course goes over teaching some of those basic interventions and skills. But the course also incorporates some opportunities for small group learning and case discussion that participants can go through to kind of help cement going through that ABCDE process and thinking about what interventions they could make. This is by no means an official outline. This is just an example. This is one I used for a BEC course I taught in Mexico in 2022. And don't pay attention too much to the individual courses. What you can kind of look at is everything in light blue represents didactics. Everything in purple is sort of small group case discussions, and everything in yellow refers to skills teaching. So just looking at this overall kind of 5-day schedule, you can see how it kind of plays out. Little didactic teaching in the morning, and in the afternoon, practicing the skills that are relevant to that topic, and then sort of repeating day to day. This is by no means hard and fast. You can technically design a BEC however you want, as long as it covers the desired material. But this is just a suggested or example of a way that can be organized that's been used in the past. And this is a specific look on how a day of the BEC might look. It is a lot of content, and it does take some time to get through. So 5 days, not an unreasonable period of time, with some pretty full days in there. So here you can see some didactics up front in the morning, break for food, some small group discussions, and then jumping into sort of case-based learning or skills-based learning. Recently, beyond those components I talked about, beyond the didactics, the skills sessions, small groups, and case discussions, there's now been made available some online courses. So there's now sort of an asynchronous component that's available. This is excellent for when you're thinking about, implementing a BEC course. It takes time, it takes resources to support and host a course, and it also pulls people away from their clinical work. So with the development of resources like this, also available on the WHO webpage, you can do sort of a hybrid course where some of the learning is done asynchronously, and you may only have to be teaching in person for, instead of 5 days, maybe 3 days, just to ensure that learners can demonstrate the necessary skills and demonstrate they have a mastery of the concepts. And all of that, again, available on the WHO website. Finally, one of the important benefits and one thing to note about the basic emergency care course is that this is a sort of internationally recognized certificate course. So if you complete the basic emergency care course, you can receive a certificate that's then internationally recognized. Because of this, however, it's important to keep the basic emergency care course as well as basic emergency care training somewhat standardized. Therefore, a lot of times in order to run an official basic emergency care course, it requires that you be or have with you a dedicated and trained basic emergency care instructor. We'll talk a little bit about how you can become a basic emergency care certified instructor, as well as resources on finding one in case you yourself are not, but still want to host a basic emergency care course. And we'll talk about that in a little bit. So that all sounds well and good. Course sounds amazing, but does it really work? And so what I want to do next is talk a little bit about some of the data surrounding the implementation of the basic emergency care course, looking at some of its efficacy. This study was one of the early pilot studies done on the BEC before its initial release, performed by Dr. Andrea Tenner and company. Basically what it did is it took sort of the early form of the BEC and kind of rolled it out in multiple different locations. So one in Tanzania, one in Uganda, one in Zambia, and rolled it out in various levels of healthcare and with learners of various levels of medical training. So they included clinical officers, they included nurses, specialist doctors, and they performed it in various different facilities as well. So they did it in regional hospitals, local healthcare centers, tertiary care, and sort of larger referral centers, sort of a whole variety of different learners as well as different environments. And what they did is they took a look at a couple of things. First, they took a look at sort of the learner's comfort level with assessing and dealing with some of the topics that are covered in the BEC. So how comfortable do they feel taking care of a sick child? How comfortable do they feel taking care of an adult who presents acutely ill? And then specifically, how comfortable do they feel assessing an airway and managing an airway? Or how comfortable do they feel assessing somebody's breathing and then making necessary interventions? And what they found, based on a pre-course survey and a post-course survey, is that in nearly every category they asked about, there was a statistically significant change in the comfort level of the learners when dealing with some of these topics. They also looked at some more objective data, and in subsequent rollouts, they started to do sort of a pre-course test looking at some of the knowledge that's contained within the course, and then followed up by a post-course test where they can assess, how much that's changed. And again, in the study by Dr. Tenner, it was found that after the implementation of the course, the baseline percentage scores changed significantly or had a statistically significant change from before the course to after the course. So basically demonstrating that the course is effective at conveying this knowledge and as a training tool for basic emergency care. Ultimately, though, with any educational intervention, the true test to determine whether a course is effective and sort of what we all strive to kind of show is that does this course have a positive impact on clinical outcomes? And recently, in 2023, there's an observational study published by Towns et al. That looked at whether the delivery of basic emergency care course in a rural hospital in Liberia actually resulted in clinical change in practice. Notably, they looked at some key markers. So they did a retrospective review of ledgers within the emergency care area, looking at how many patients who presented with acute complaints got triaged and sort of got assessed with all the components that are included in the BEC. So for their airway or for their breathing, did they get a respiratory rate? Did they get an oxygen saturation? For shock, did they get a heart rate? Did they get a blood pressure? And so they looked for about a year leading up to the basic emergency care course, how often this was happening, and then sort of continued to observe following the implementation of the course, how often it happened in the subsequent months to year. And again, what they found is that there was a significant increase in the amount of times that patients got fully assessed, had all of these important aspects of their assessment done. So airway, breathing, circulation, disability, which was definitely promising. And many other studies are out there. As I mentioned before, the course has now been rolled out in over 60 different countries worldwide. And a lot of the studies are showing some sort of positive benefit, whether it's just in sort of learner comfort, learner knowledge retention, and then what we all sort of strive to do, sort of showing that there is some benefit in change in clinical practice, which is what we all hope for with any educational intervention. So taking this into account, come 2023 and recent years, looking at some of these studies that are coming out with some promising results, the WHO has now actually incorporated, including the BEC specifically, in some of its recent recommendations. So in 2023, it sort of released a new statement, sort of WHA 76.2, which talks about the importance of having skills-based training and incorporating skills-based training when thinking about developing emergency care. And specifically the importance of training first contact providers using the WHO basic emergency care course. So basically, long way of saying that the WHO developed this course and that over the course of the last several years, it's been showing promise in its efficacy in improving the comfort levels of healthcare providers of all levels of training, improving knowledge acquisition, and also having some positive impacts on patient care. So that's all well and good. And I'm sure after hearing all that, you guys are all super excited. You're like, let's go out, let's take this everywhere, let's get this started. And to that, I would say I love your enthusiasm. But it is important to remember that the BEC, as it stands and is printed on the WHO website, is not a one size fits all. And that even though there are a lot of materials for teaching that the course provides, there are also a lot of other considerations we need to take into account whenever we're going to another region or another area, or even locally, and thinking about implementing an educational curriculum or educational intervention. So as a kind of quick aside, what I want to do is talk briefly about what other special considerations you may need to think about and take into account if you're ever thinking about starting a BEC program or implementing a BEC training with local or global partners. Right. So one tool, and I could spend days talking about the development of curricula and the implementation of educational initiatives. But we only have a limited amount of time. So I really want to start with just one kind of curriculum development tool that I find incredibly helpful, and it's very popular within sort of medical education literature when it comes to developing curricula. And that is the Kearns 6-step model for curriculum development. If you're familiar with this tool, great. If not, it can be easily found online. We're not going to go into it in too much detail, but we're going to go over some of the basic steps and sort of use that to think about what you can consider when starting to implement a BEC or thinking about whether it would be worthwhile to start a basic emergency care course. So the basic steps of the Kearns model for curriculum development is fairly straightforward and starts with problem identification. Within the context of a basic emergency care course lecture, you may think something like, oh, the need for the problem identification is already there. It's the development of emergency care. However, it's important to stop here and think back to some previous lectures in the series, including the Global Health Equity lecture and ethics. And remember that when thinking about problem identification and needs assessments, that this is something that really needs to be self-determined, right? Not something that's imposed. Meaning, when you're working with partners, either locally or globally, you don't want to just come in with predetermined ideas saying like, you guys need a basic emergency care course, I'm going to do it for you. It really needs to be a discussion with your global partners or whatever groups you're working with and determining what is important to them first. And then if basic emergency care is a focus of that group and something they want to improve, then maybe pursuing the basic emergency care course. So sort of horse before the cart kind of thing. Always, 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 whenever working with partners locally, globally, the problem identification of what is important to that group is self-determined, and you don't want to just go and impose something, even if there's good data suggesting that this course works. It may not be the priority of a group you're working with. Step 2 is sort of a focused needs assessment. I imagine many of you guys are familiar with this process, but basically this step focuses on once you've determined, or if the group has determined that emergency care is something they want to improve, the next step is to determine getting to know and getting to learn more about the learners themselves, as well as the learning environment. While the BEC is a standardized course, how you think about delivering that material and how you go about it can change dramatically depending on the group you're working with. This can include social and cultural considerations and practices, levels of education of the learners you're working with, whether it be very advanced in teaching a group of physicians or beginner level learners or lay people who are working in emergency care areas as medical assistants, those kind of things. So all this is important when you're doing your needs assessment, sort of looking at who is the group of learners that I'm teaching, what is the context in which I'm teaching it, and how can I use that information to better tailor this sort of prefabricated curriculum to best suit the group that I'm working with. The third step sort of focuses on goals and objectives. And again, points to the fact that one group's hopes and what they might want to get out of basic emergency care training may vary from one group to the other, right? For example, certain content in the basic emergency care course is standardized, right? There's a little bit on burns within the shock component. There's a little bit on snake bites and sort of the altered mental status and environmental components. But the importance of some of those topics may vary depending on the region you're in. So if you're working with a group, for instance, that sees a large amount of burns. Maybe they use kerosene lamps, things like that. Maybe, including the minimum amount you need to complete the requirements of the course, but also possibly expanding on burns if that's something that's important to the group you're working with. Similar with snake bites. If you're working in an area with no poisonous snakes, such as Haiti, maybe spending a ton of time on the snake bite portion is not worthwhile, and you can just do the minimum required to complete the certification. However, if you work in an area with a lot of snake bites, it may be you to sort of include extra information, spend some extra time making it so that it's more worthwhile and customized to meet the needs of the group that they've self-determined. Step 4 are sort of talks about sort of educational strategies. And group steps 5 and 6 sort of get into some more granular detail about the logistics of how you're going to deliver the curriculum itself. They can focus on what educational strategies you're going to use. Is it going to be primarily a didactic? Are you going to try to do some reading ahead of time or using some of the online curricula to supplement your course that folks will have to complete before you get there? All that stuff you consider when you think about what educational strategies to include and selecting strategies that will work best with the group you're working with. For step 5, implementation, there are also factors such as materials, costs, and some of the practicalities to consider that the prepackaged BEC course won't address. For instance, a lot of the material of the BEC, as it comes prepackaged from the WHO, relies heavily on didactics. And a lot of times that's delivered through computers and projectors, so sort of a PowerPoint kind of model. But you may be working where that's not available. And how do you take this material that's prefabricated and adapt it to that particular learning environment? Whether that's translating slides to old school flip charts or transitioning just to oral presentations can depend largely on what's available and where you're working. Finally, these were just other examples of materials. So like there's a lot of skills sessions within the basic emergency care course. Do you have mannequins with which you can demonstrate these skills? Do you need mannequins? Can you use participants sort of practicing skills on each other? Or do you need to improvise? And in this case, we were using pillows when we were talking about resuscitation with the assistance of a very lovely street dog named Cacahuate, which means peanut. But just taking into account how you're going to implement and how you're going to actually deliver some of the materials included in the course. This also refers to you yourself or instructors as a resource, right? Knowing how many participants you're going to be teaching and what sort of ratio of instructors to learners that you'll need to deliver the course effectively. The course does involve a lot of small group exercises, case-based discussions, as well as some skills teaching, which generally benefits from more instructors with smaller groups. This isn't always feasible. Ideally, it's nice to have a ratio of, 1 instructor to 4 to 6 learners, but that's not always possible. And just be thinking about how you can most efficiently get the course done with the resources you have available. And then finally, the last step of the Kern's 6-step curriculum development model is you need some sort of method for evaluation and feedback, right? And it's important to consider how you're going to sort of evaluate the course that you deliver. Because it's very important whenever you're going to do an educational intervention or whenever you're going to deliver a course or deliver a curriculum, you want to be able to show that it was actually efficacious. Not so much for publication reasons necessarily, although my section chief would probably argue differently. The real importance comes from simply being able to determine if the curriculum is working or not. And is it working in this context that you're using it? Because if you deliver the course and it was unsuccessful, or you don't see a change in confidence, or you don't see a change in knowledge acquisition, or you don't see a change in clinical outcomes, what can we do going forward to make changes to where it can be more effective and examine where we can improve? Great. So that was sort of a brief foray into medical education in general, kind of a passion project of mine. But kind of getting back to the BEC, we've now looked at sort of why it's important and why it was developed, some of the initial data surrounding its implementation and some of the preliminary data, as well as subsequent data showing its efficacy. We've talked about some other considerations, and now we're going to sort of talk about kind of where the BEC is headed, what opportunities are out there, and then how you guys can get involved. So the BEC, one of the easiest ways, especially if you guys in the audience are emergency medicine residents or emergency medicine fellows, one of the easiest ways to get involved with a basic emergency care course is through sort of the SAEM annual conference. So the Global Emergency Medicine Academy within the Society of Academic Emergency Medicine, or SAEM, puts on an annual sort of basic emergency care course training of the trainers, where you can both go through the course as a participant and then actually go through a training of the trainers to where you can become a certified BEC trainer. It's a well-run course. The registration for information is up here on the screen, but it can be found very easily with a simple Google of SAEM Basic Emergency Care course. Registration is still open for this next upcoming conference, but if you miss it this year, it's always available. It's available year to year, and it's a great way to get trained, especially if you're thinking about starting a global EM fellowship. It's a great skill to have and a great certification to have under your belt. Because it's a very sort of widely applicable course. If you are interested in sort of developing emergency care and emergency care education initiatives, and you want to do a BEC course or implement a BEC course, but you're not trained as an instructor, there is a sort of database of trained instructors kind of by region that you can reach out to. So you can say, hey, I'm interested in starting a BEC course in this region. Are there local instructors that I can reach out to that can help me teach the course and actually deliver certificates of completion to the participants? As I mentioned before, the BEC has been rolled out in over 60 different countries. There are officially trained BEC trainers in sort of all regions of the world. And so if you want to put on a BEC course, but you yourself are not a trained trainer, there are ways you can reach out and sort of find local trainers in your area that might be able to help out and deliver your course. One of the ways is going through the WHO website, and if you can use this QR code here, or you can email this email on the screen and sort of inquire about local BEC trainers. You can also go through the ICRC, the International Committee of the Red Cross, and reach out to that local chapter, and they should also be able to kind of direct you to trainers within an area or region that might be able to help out and facilitate your basic emergency care course. Finally, there is a lot of growth on the horizon for the basic emergency care course. It's already been rolled out in 60 different countries, but the WHO is continuing to push the delivery of this course. There's been a recent sort of drive or initiative to get nurses in 25 different countries all trained in the BEC by 2025. So if you're, current EM resident and you're thinking about global emergency, global health and emergency medicine, there's going to be a lot of opportunity in the coming years for BEC trained physicians. And so if you're thinking about getting the training, again, definitely a good certification to have, and it can open a lot of doors for some cool opportunities down the line. One notable opportunity is that an email went out recently sort of requesting or looking for trainers who could help out giving the BEC course in the Ukraine, sort of training first-line providers in the Ukraine on basic emergency care and completing the WHO basic emergency care course. So the course can take you a lot of places. It's very much in demand, and they're sort of it's expanding in a lot of different areas. So if you're interested, reach out definitely to WHO, the ICRC. Look at maybe going to SAEM, getting certified. You're also welcome to reach out to me. My contact information is on the University of Chicago webpage. Always happy to talk more about it. Feel free to send me an email. Cool. So that's about all I have. Just to recap, the Basic Emergency Care course is a publicly available training course designed for people of all levels of medical training. It was developed in response for a need to improve emergency care globally, and has actually shown a lot of promise and as an effective way to train frontline healthcare workers in the basic assessment and management of common emergent conditions. But it's always important to work with and prioritize local interests and to sort of not just deliver the basic emergency care course, but also to think about some of the special considerations whenever you're implementing an educational initiative, especially globally. Going forward, I anticipate the BEC trainers will continue to be in high demand. And therefore, there are lots of opportunities for you as residents and fellows to get involved and use the course in your work in the future. All right, that's all I got. Thank you so much. Hope you enjoyed it. And again, feel free to reach out with any questions, comments, concerns, and hopefully see you in future months. All right, thank you.